Hi, my name is Bob Jarman, and I'm going to take you on a journey through interpreting echocardiography clips in emergencies. These are the aims of the presentation. Okay, for you to understand echo, you need to understand a little bit about ultrasound physics. Now, simply, it can be about balls. If you think about it this way, it's easy. So, if you have a ball and you throw it at a particular velocity, in a certain amount of time, it would have travelled a certain amount of distance. Easy, eh? So, distance is velocity times time, and that will give you a distance in meters. In ultrasound, the ultrasound beam that is being generated, or the ultrasound pulse, is getting sent from the probe or transducer, and occasionally it's hitting things that are bouncing the ball back. So, how far has the ball travelled before it was bounced back? Well, if we know it's going at a certain distance, then that will be the velocity times the time divided by 2. So basically, it's there and back. Okay, so we can think about balls, but imagine our ball is actually a little pulse of ultrasound. So it's sound waves, not balls, not light, nothing else, just sound waves. Okay, so in most soft tissues, the ultrasound machine will anticipate that the sound waves are travelling at 1540 meters a second. And this in most tissues is true, apart from in some tissues it'll be slightly slower and some slightly faster. Now, this is a typical picture of a probe or a transducer, and this is going to be used for doing echocardiography. Now, you can see there's a handle, which is here, and at the end there, this is the footprint, and underneath this footprint, we have lots of crystals. These are PZT crystals. So when a sound wave hits them, they generate an electricity, and vice versa. So this is a great way for the ultrasound machine to send an electric signal to the probe, generate an ultrasound pulse, and then an ultrasound pulse, when it's sent back, will actually create another electronic signal. So it's a good electrical to mechanical uh, converter and vice versa. So the way that these crystals work is they generate a nice beam. So it's very flat and it's very thin, and you see that it spreads out. So it's in a pretty much in a sort of two-dimensional plane. And some people liken it to a wallpaper scraper, but you may not know what one of those are if you don't do things like decorating. Okay, so we've got our probe, and as you can see, it's sending off all these little ultrasound pulses. They're hitting objects, and then they're getting bounced back. And this happens many thousands of times a second. So let's go through that again. So you see, it's working in a sequence, and as it works in a sequence, it generates the image on the screen. Now, it knows where those images are on the screen because of the time it's taken. So, what causes the ultrasound energy to be reflected back? Well, sometimes, remember I told you the speed of sound in tissues is usually about 1540 meters a second. Well, in some tissues, it's actually very, very different. So, air is one where the speed of sound only travels at 330 meters a second. And in bone, it travels much faster at over 4,000 meters a second. So, if there's a big difference in how fast the sound travels in a particular medium, at the interface between those tissues, there'll be a big reflection back. And that's shown as a very white area on the ultrasound screen. So, if it's white, it's a big reflecting area. If it's black, it's not a reflecting area. And then there's obviously shades of grey in between. And remember, the ultrasound picture is being refreshed many thousands of times a second in order for you to see things in real time. So impedance is what we call the particular type of tissue structure that causes the speed of sound to travel at a certain velocity. So things such as bone are very dense and quite rigid, and so their impedance value actually affects how fast sound travels in those structures. So, have you fallen asleep yet? If not, let's continue. So, with a big difference in speed of sound, we get more reflection. So, it's easy, yeah? So, this lovely table here will help you understand some of the particular speed of sound values. Now, the right-hand column is the impedance, and as you can see, most of them are around 1.5, but there's a few outliers, such as air and skull. In the middle one, the density is shown, and you can see there's a big difference in densities. And then this one here, this is money. Yep, this is the speed of sound in that particular tissue, and this gives you an idea of what sort of variance you might see. So for everything apart from skull and air, there's a very big difference in, a very little difference. So air is very slow, bone and skull is very fast. Okay, so let's just have a look at the basic modes of the ultrasound machine. The one that we use most of the time is B mode. And as you can see, this generates an image on the screen of ideally the anatomy we're looking at. So this is actually a parasternal long axis, and we'll go into that a bit more later. But it's showing the heart beating. So it's refreshing it quite often, and it's actually showing us the structures that we want to see. So as you can see, there's some areas that are white and some areas that are black and areas that are grey in between. So the further away from the top of the screen, the more further away it is from the probe. And obviously those sound waves that have been reflected back from the lower part of the screen have taken longer to get back to the probe. And as you can see, it looks a bit like a cake shape or a slice of pie shape. So this is a typical type of shape of image that we get using echo, and it's called a sector. Okay, so B mode is the main one, and it stands for brightness mode. Now, some of you might have driven too fast and got clocked by a speeding camera. And so speeding cameras work because they use Doppler. And Doppler is something we encounter every day in our lives when we hear sirens and things of police cars. And as the police car comes towards you, it appears that the siren sounds at a higher frequency than when it's travelling away from you. This is because the sound is influenced by the velocity of the moving target. So if we send some ultrasound pulses at a particular velocity to a moving target, which is often going to be things like red blood cells, if they're moving, then the frequency that gets returned will be different. And there is a lovely equation, but I'm sure you don't really want to go into that now. Okay, so we can use Doppler to give us pictures of blood flow. They can also be used for looking at tissue movements too. But commonly in echo, we actually use blood flow. And this is just a picture of blood moving through a carotid artery. Now, the thing to remember is the colour doesn't necessarily represent what particular type of blood vessel it is, so whether it's artery or vein, but it does represent whether it's coming towards or away from the probe. So we often say Bart, as in Bart Simpson. So blue away and red towards. Okay, so that's the physics over. You're probably going to be quite relieved now. Okay, so let's have a look at the views of the heart. Here's a typical view sort of range that we will see. And as you can see, there's parasternal views, apical views, and subcostal views. Now, if you imagine the heart is actually a mediastinal structure, so it sits really behind the sternum, going over slightly to the left. So really the way we have to look at these windows of the heart is to often go through or under where ribs are, and that's why we use quite a small probe footprint, and this is able to look through and see the heart from its hiding behind the sternum and in the rib cage. And often as well it can be difficult to see because there is aerated lung. And remember, when there's air around, it causes big reflection when it's next to soft tissues. So, as a favour to you all, I took a picture of my awesome athletic body, and I've mapped on it the typical windows. Now, we're not going to look at the suprasternal views today, but we're going to look at the parasternal windows, subcostal windows, and apical windows. And they all give you slightly different information. But the parasternal windows are taken to the left of the sternum. Subcostal is under the xiphoid process or xiphisternum, and the apical one is around where the apex beat is. Obviously, you still do the apex beat because that's part of your clinical training. Let's have a look at the parasternal views first. So one of the common ones that we often use is a parasternal long axis. Now imagine the axis of the heart in the chest doesn't actually go up and down or side to side. It's in a line really from the right shoulder down to the left hip. And we often go in the third or fourth intercostal space to the left of the sternum. And as you can see, we get a typical sort of view of the heart in long section. And this includes the left atrium, the mitral valve, the left ventricle, the aortic valve, and the root of the aorta. There's also a small part of the right ventricle, the bit that's adjacent to the pulmonary valve. You don't see the pulmonary valve on this view, but you see the part of the right ventricle near it, and that's called the right ventricular outflow tract. So here's a typical parasternal long axis view. So you can see this is the left atrium going through the mitral valve into the left ventricle, and then blood is being squeezed out during systole through the aortic valve that opens and the root of the aorta. So the root of the aorta is a bit like a spring onion. It has a slight bulge at the base, and then it goes up obviously to the arch. And this is the right ventricular outflow tract on the top. And as you can see, it's quite dynamic, so it's preferable for your heart to be beating all the time. That's why when you're assessing it in different phases of the cardiac cycle. Now the little round thing to the bottom is a descending thoracic aorta. And that very bright line at the bottom, which is very white, is the pericardium, which is obviously next to aerated lung. And that's why it's shown back as a big reflection. Okay, so let's have a look at the parasternal short axis views. Now, if we've been looking in the long axis, which is from the right shoulder down to the left hip, if we rotate our probe 90 degrees, then we can look through the heart in a transverse axis. So this is the parasternal short axis views. Now, depending which way you're angling, it's like if you could imagine a loaf of bread that's been sliced. You can slice it at now one end, in the middle, or now the other end. And wherever you slice it, there'll be a slightly different view. So there's three typical views that we can get in the parasternal short axis. So with this one, I'll show you the three in a minute, but you can see there is a nice one which we call the dancing donut view, because you can see it's nice and round. That's the left ventricle. Then there's two bulges into the cavity of the left ventricle, which are the papillary muscles. Now remember, the papillary muscles via the chorda tendineae attached to the mitral valves leaflets. And if you can consider a croissant on top of the donut to the left and at the top, that's the right ventricle. So it has that appearance of a croissant, whereas the left ventricle looks like a donut on this view. Okay, so here's a schematic just to give you an idea. So the view we're looking at is down near the apex, and was this one on the left of the screen. If we angle up slightly, then we go past the papillary muscles and concentrate on getting the mitral valve leaflets in the middle of the screen. This often looks like a fish mouth, opening and closing. And then when we angle up even further, we get where the aortic valve level is. Now this provides a bit of information about the right side of the heart too, but this view is called a Mercedes view because the aortic valve has 3 cusps and looks like a Mercedes logo. Okay, let's have a look at all those images together. So on the top left is at the papillary muscle level, and do you see what I mean by dancing donut? It really does move. The one in the top right of the screen is a mitral valve, so it looks like a pair of lips opening and closing, or some people think about it as a fish mouth or being kissed by your grandma. And on the bottom we've got the view with the Mercedes, so it's basically the aortic valve opening and closing. So below the aortic valve is a left atrium, below and to the left of the aortic valve is a right atrium, and you can just make out to the left of the aortic valve is something opening and closing, and that's a tricuspid valve, and something to about 2 o'clock position on the aortic valve is another thing that's opening and closing, that's a pulmonary valve. Okay, with the subcostal views, they're typically a view that's done in cardiac arrest, but they provide good information and they're easy to do on most people. They will give you information about both chambers of the heart side by side, and in order to get that, the probe is placed flat in the epigastrium and directed up into the mediastinum, slightly to the left shoulder. This view will give you a view of the right ventricle and right atrium, which will be closest to the liver, and then further away from the liver will be depicted at the top, or the sort of closest to the transducer. So furthest away will be the left ventricle. So you see the left ventricle and left atrium below, and you'll see tricuspid and mitral valves. So here's a typical subcostal 4-chamber image, and you can see at the top of the screen is a tissue that is liver, and then you can see the heart beating under the liver. Now obviously this is inverted, so in reality it's the other way around, but don't get bogged down in trying to sort of visualize it yourself at the moment. So you can see there's like a triangular shaped right ventricle at the top closest to the liver, and to the left of that is a right atrium, and then you can see the thicker walled left ventricle contracting with a mitral valve, and underneath the mitral valve at the bottom of the screen is the left atrium. Now there's some views that can be achieved from the apex of the heart, and these are called apical windows, and there's actually quite a few depending on which orientation you have your transducer. The typical one that most people will start off with is the apical 4-chamber, and basically we're aiming our probe up from the apex beat really up to the right shoulder, and this will give us a view of both chambers side by side. So on the left there'll be the right ventricle, tricuspid valve, and below it the right atrium, and on the right the thicker walled left ventricle, mitral valve, and left atrium below. This is a typical appearance of an apical 4-chamber view. So on the left you can see the right ventricle with its thinner walls, tricuspid valve, and below the tricuspid valve on the left side is a right atrium. And then on the right of the screen you can see the main part of the left ventricle, tricuspid valve, the mitral valve, and below that the left atrium. Now if we rotate our probe anti-clockwise, we lose seeing both chambers side by side, and it just then brings the left ventricle only into view. And this is a good view for looking at the inferior wall. So The top obviously is the left ventricle chamber with the mitral valve and below the left atrium. But the part of the left ventricle that we see on the left is the inferior wall. So this is a very good view if you want to look for any disease process that's affected the inferior wall of the left ventricle. So this is what the apical 2 chamber looks like. Now, with slightly different rotations of the probe and angulations, we can also bring another 2 views, and that's the apical 3 chamber and apical 5 chamber. So let's show you what they are. So on the top left is the apical 5 chamber view. Now you might think this actually looks very similar to an apical 4 chamber, and you're absolutely right, it does. But all we've done is slightly angulated the probe up so it's shining more towards the top of the right shoulder than, say, the right shoulder itself. So the angle has slightly changed and angled more upwards. And this brings into view the aortic valve and basically the root of the aorta. So you can see in the middle, between the left and right, is a valve moving. This is the aortic valve. Now, it's a good view to have this because using things like Doppler evaluation, you can look at blood flow going through the aortic valve. On the bottom right, there's a view that actually looks very similar to a parasternal long axis, but instead of being fairly horizontal, it's actually vertical. So this is the apical 3 chamber view, and it's a 3 chamber because it shows the aortic outflow. So it's not really a chamber, but like the 5 chamber, that's not really a chamber too. But when it shows the aortic outflow, then it's often termed, given an extra chamber on the number. So this one is a bit similar to the parasternal long axis, but is actually a view taken at the apex. And this shows the same features as the parasternal long axis. So the left atrium mitral valve into the left ventricle and then out through the through the aortic valve and root of the aorta. And to the very right of the screen, not clearly seen, is obviously the right ventricular outflow tract. Okay, we're going to look at the structures seen in the views in a little bit more detail, because that will help you understand exactly what you're looking at. Okay, let's have a look at the structures in a little bit more detail. I want you to really look at the images a bit more closely to fully understand what the normal heart structure and function looks like. Okay, so with regards to the structure, we can see that this is a parasternal long axis. So on the left side of the screen would be where the apex is, although it's not seen on this view. On the right is the root of the aorta. So starting off really at the bottom left chamber, we've got the left atrium. So the left atrium is normally no more than about 4 centimeters. And if you wanted to just have a look and see what a centimeter would look like in comparison, to the right of the sector image is little blue dots, and these blue dots are spaced at 1 centimeter markings. So you can easily just have a quick look at those and see how the chamber size corresponds. So you can see this left atrium is smaller than 4 centimeters. So to the left of the left atrium is the mitral valve, and there's an anterior leaflet, which is the one at the top, and a posterior leaflet, one at the bottom, and they're connected by the chorda tendineae to the papillary muscles. Now the anterior leaflet is much more mobile, and you can see that as the blood flows through in diastole, i.e. the filling phase and relaxation phase of the heart, the anterior leaflet flips up and almost touches the septal wall at the top of the left ventricle. This is a good indication of flow and valve functioning normally. So just have a look at the movements of the mitral valve, because that's the way it should move. And the mitral valve also should be no more than about 4 millimeters of thickness to its leaflets. And you can see, looking at the leaflets just on a quick eyeball, that they're not thickened or overtly moving in an abnormal way. So into the left ventricle, we have the main chamber itself, which is black, and then the walls of the left ventricle around it. So at the bottom is the posterior wall, and that goes along to the apex, which you can't see on this view, and then swings around, and at the top is the septal wall. Okay, so when blood's been pumped out of the left ventricle, it's going to go through the aortic valve. So we can see the aortic valve, it's at the middle right of the screen, and it's opening and closing. And this shouldn't look as thick as a mitral valve. So really anything more than about 1 millimeter of thickness is usually abnormal. And you can see that the valve, pretty much when it closes, is closed in the essentially the middle of the aortic sort of outflow tract. And then there's a dilation of the aortic root, which is the sinus of Valsalva. This is where the coronary arteries come off, but you can't see them on this view. Then, of course, above there is the right ventricular outflow tract. So it's not the whole part of the right ventricle, it's just a small part of it that's seen on this view. Other things to note is at the bottom of the screen, on the right, is a round black structure below the left atrium. This is actually descending thoracic aorta. So it's the aorta that's gone around the arch and is on its way down. So we're seeing that in cross section, and that's why it looks round. And then to the left of the aortic, the descending thoracic aorta, is the pericardium, which the posterior wall of the left ventricle is against. And you see this shows up as very bright and white because underneath that is aerated lung, and that's obviously causing big reflections. Okay, let's have a look at the parasternal short axis views now. So remember, depending on which way we angle the probe, we can get a different slice of the heart in cross section, and that's what the parasternal views bring you. So looking on the top left, we have the slice through the papillary muscle down towards the apex, and the papillary muscles are going to be about 4 and 8 o'clock on the clock face. So it's perfectly round and it's contracting, and on the top of it you can see the croissant shaped right ventricle in cross section too. Now interestingly, looking at the this part of the heart will show you all the walls of the left ventricle in cross section. So probably between about 11 and 1 o'clock is the anteroseptal wall. Between 1 and 2 o'clock is the anterior wall. Between 2 and 4 o'clock is the lateral wall. Between 4 and 6 is the posterior wall. Between 6 and 8 is the inferior wall. So you can see that there's various parts of the wall seen there. So really at the top, the anterior septal area, and at the bottom, the inferior and posterior aspects. Now just bear that in mind because the 3 main blood supplies to the left ventricle are the left anterior descending, the circumflex, and the right coronary artery. So the anterior and anterior septal area is supplied by the left anterior descending. The lateral and posterior walls are supplied by the circumflex artery on the whole, and the inferior and right ventricular walls are supplied by the right coronary artery. So each of those zones can reflect whether or not there's a problem with the artery for that particular area. Now, as we go to the top of the right of the screen, we're taking the slice now through the mitral valve. So the mitral valve is in the middle of the screen with the anterior leaflet at the top and the posterior leaflet at the bottom. And you see that's contracting, and the walls are still the same as what we said before. So it's another sort of cross-section of the left ventricle wall with the anterior septal area at the top and the posterior inferior segments at the bottom. Now, at the bottom of the screen is the aortic view of the Mercedes window, and below the Mercedes valve, of course, the Mercedes or aortic valve in this case has 3 cusps, and below that is the left atrium. Below and to the left of the screen, there's a right atrium, and you see it's separated from the left atrium by quite a thin wall. Then to the left of the aortic valve on this view, you can see there's a valve opening which is tricuspid, and then above the aortic valve is the right ventricle, and then about 2 o'clock position on the aortic valve is another valve opening which is a pulmonary valve, and that obviously goes to the pulmonary artery into the lungs. Okay, so let's move on to the subcostal views. So, on the subcostal views, we have the left lobe of the liver, which is seen at the top of the screen. Then adjacent to that is the right ventricle, which looks triangular in shape. Now, it looks much smaller than the left ventricle on this, but the right ventricle tends to wrap around the left ventricle, so we're only seeing a sort of a fairly small part of it. The other thing to notice is that the left ventricle has much thicker walls to contract, and you can see the mitral valve at the base of the left ventricle, and below that the left atrium, and across the septal wall is the right atrium. Now the ratio is at on this view, the right side of the heart shouldn't be more than 2/3 the width of the left side of the heart. So if you were to look at where the mitral valve is on the annular plane there, it certainly is wider in the left side than it is on the right side. So conditions that could make that reverse, so things like a massive pulmonary embolus where there's an obstruction to the flow of blood through the lungs, causes an increase in the pressure on the right side, which dilates and balloons up. And obviously if there's a big blockage in the lungs due to an embolus, there's not a lot of blood going back into the left ventricle, and so that often shrinks and looks very small. So looking at the ratio between the right and the left side on this view is very, very good indeed to evaluate acute problems such as a massive pulmonary embolus. So looking at the apical views now, you can see on the right of the screen there's a larger chamber left side, which is the left ventricle and left atrium. On the left side is a right ventricle and tricuspid valve and right atrium. So the same principles apply with regards to the width. It's much wider on the left ventricle than it is on the right side, and so it should be the 2/3 rule. So remember, the right side shouldn't be more than 2/3 the width of the left side. Now, there may be some chronic conditions as well that can cause this, not just things like acute pulmonary embolus, but your role is really just to spot that there is a problem, not necessarily conclude it's due to a particular condition. So remember, the width and the ratio is important. And one of the best places to look at that is where the mitral and tricuspid valves are. So that sort of plane there. Now, if you're looking at the left ventricle in a bit more detail, we can see that at the right of the screen, that wall is a lateral wall. On the left of the screen is the septal wall. But this is also a good view of the apex. And we haven't seen the apex clearly in some of the parasternal views. And in this case, we can do. So we can see the apex as well. And on this image, it's actually fairly dark. Okay, so let's have a look at the apical 2-chamber view. Now remember, this is a good one to see the inferior wall of the left ventricle, and that's the wall that you can see on the left of the screen. So on the top of the screen is the left ventricle, then the mitral valve isn't clearly seen in cross section, but you can see there's movement there, and then below that is the left atrium. So the wall on the left is the inferior wall, and you can also see the apex here as well. Okay, let's have a look at the apical 5 chamber, which is the top left image, and the apical 3 chamber, which is the bottom right image. So the apical 5 chamber, there is a slight angulation of the probe which is brought in to view the left ventricular outflow tract. And you can see the aortic valve is seen opening and closing. By doing this view, we sacrifice to some degree the mitral valve view, which is not clearly seen. On the bottom right is the apical 3 chamber, which is really similar to the parasternal long axis, but shown in a more vertical view. So at the bottom left is the left atrium with the mitral valve opening up into the left ventricle, and the wall of the left ventricle on the left side of the screen is a posterior wall. We can see the apex in this view, which is often not seen in the parasternal long axis. And then the wall that is seen on the right, or the sort of left ventricle wall on the right, is the septal wall. Then we can see the aortic outflow tract, including the aortic valve opening and closing, and the root of the aorta, the sinus of Valsalva, which remember looks a little bit like a spring onion. Okay, let's just look at those images again, but instead of looking at the structures, we'll just look at the way the heart actually moves. So you get an appreciation of the normal function of the heart during the cardiac cycle. So back to the parasternal long axis, I want you to really concentrate on the left ventricle here. I want you to look at how it moves during its contraction phase or systolic phase. So there is a papillary muscles making the actual border of the posterior part of the heart on the bottom left difficult to totally appreciate because of the chordae and papillary muscles around it. But on the whole, the left ventricle muscle, if you think about it, should be in its relaxed phase, i.e. when it's not contracting, about a centimetre. It ranges between about 9 and 12 millimeters, but a centimetre is a good rule of thumb. And remember, we can estimate what a centimetre looks like by looking at the markings on the scale on the right of the sector image. So these little dots are spaced at 1 centimetre. So if you think about that, in a relaxed state, the myocardium, or the left ventricle, is approximately a centimetre thick before it contracts. So that's what the normal dimensions of the muscles should be in the relaxed state. However, as you can notice, when the systolic phase occurs, the actual wall thickens. So we normally expect a 30 to 40% increase in the thickness of the left ventricular wall during systole. Now the left ventricle has fibres that run in different directions embedded in it, and some of them cause thickening, some of them cause radial contraction. So as you can see, the actual width, internal width of the chamber is reduced by about a third during systole, and so that's easy to see on this view. And often you can do measurements of these things, but really just by looking for the thickening of the left ventricular wall area of interest you're looking at. So at the top that's the septum, at the bottom it's the posterior wall. You can see if it's functioning normally. And as we said before, parts of the left ventricle are supplied by different arteries. So for instance, there might be a septal or anterior septal an apical problem if there is a left anterior descending occlusion. And sometimes you'll see this well before any ECG changes on echo. So looking at the thickening, looking at the radial contraction, And also there is some spiral fibres which cause a shortening of the length, but this isn't very well appreciated on this view. But really the key message is look at the thickening by 30 to 40% and look at radial contraction, i.e. a narrowing of the internal lumen of the left ventricle due to contraction of the left ventricle muscle by about a third in this view. That's actually called fractional shortening if you're interested. Another thing that we can use as a marker of good function is the way the mitral valve flips up and almost touches the septal wall during diastole. And you can see that clearly. The anterior leaflet of the mitral valve is flipping up and almost touching the septal wall. So that's good. If you can imagine if there was lots of people and the fire alarm went and you all ran out of the door very quickly and it was through double doors, the door would open really wide and really fast to reflect the number of people and the speed at which you're going at. If there's only one person who was shuffling along at very low speed, you wouldn't imagine the door would open very wide or very rapidly. And that's the way to think about the mitral valve. If you're really interested, this way the mitral valve opens and closes is called the EPSS, the E-point septal separation. But I expect you remember that for at least 5 seconds before it completely loses memory. But you don't need to know its name, you just need to look at it and say, does that happen? Okay, let's have a look at the parasternal short axis views. So remember, this is another good one to look at all the particular walls of the left ventricle in cross section. Now, it doesn't show you the whole of the inferior wall or anterior wall, for instance, but it just shows you that particular slice what it's doing. So, same thing again. If you were to look at the what's happening during systole, the left ventricle is thickening by about 30-40%. So normally it should be about a centimetre in thickness in its resting phase, and it's contracting by 30 to 40% during systole. Another good thing to do is actually, if you imagine sticking your thumb in the middle of the dancing left ventricle donut, all the walls should come towards it, and that reflects a radial contraction. So the radial contraction inwards should reduce the diameter, the internal diameter of the left ventricle by about a third during contraction. So that's called fractional shortening. And you can see on this view on the top right the mitral valve view, and you can see the mitral valve and how it's moving as well, but also another good view of the left ventricular wall function. On the bottom one we don't actually get to see much in the way of the function, but we can certainly see the right side, which is quite elusive. Certainly seeing things like the pulmonary valve is not seen that often on a lot of our echo views. Okay, so looking at the subcostal forechamber, you can see the septal wall, most of the apex, and the lateral wall on this view. And again, look at its normal dimensions and how it thickens during systole, and also how there's radial contraction inwards to reduce the internal diameter of the left ventricle. So, same thing again, only left ventricular wall seen on the left is the septum, going up to the apex, and then the lateral wall on the right. Now, the mitral valve does look a bit weird because you're seeing something at the end of the anterior leaflet that seems to be flapping around a bit. But so you don't necessarily need to know what it is, but that there's something that looks unusual and abnormal. But concentrate on the left ventricular wall again, and you can see it should be about a centimetre thick, and it's contracting by about 30 to 40% during systole. And on this view, you can actually see there is a bit of a shortening of the length of the left ventricle on systole, and you can see that because it lifts up the little ring of tissue, which we call the annulus of the mitral valve, when it does that. And also the diameter of the internal diameter of the left ventricle is reduced too. Now on the right side, you can see that obviously the right side isn't bigger than the left side, and the annulus of the tricuspid valve, which is a valve seen on the left of the screen, actually moves up even more than on the left side. This is because a lot of the fibers, the muscle fibers on the right ventricle, are in a fairly longitudinal direction. So although it's not totally reliable, it can give you an indication of right ventricular function too. So this is a view of the apical 2 chamber, and we've seen this one before, so we know the inferior wall is on the left and the apex on the top. So the same things apply. How thick is it in its diastole phase, and how much does it thicken during systole? And also, does the internal diameter reduce by about 30%? So same things here with the 5th chamber and the 3rd chamber. Just, you know the structures, start looking at the movement and how it goes in systole, and certainly with regards to the left ventricle. Okay, so let's have a look at some abnormal collections of fluid or effusions around the heart. Now, you can see on this view, there is the subcostal 4-chamber view. So, you can see the 4 chambers of the heart moving, and there is the right side on the top part of the heart, so the right ventricle and right atrium. Now, there is a little bit of movement of the probe here, but you get the idea that you can see the right side at the top and the left side with left ventricle and left atrium at the bottom side. Now, it looks weird because between the left lobe of the liver and the right ventricle, there's a black stripe of fluid all the way around. Now, fluid, in most cases, will look black on ultrasound. So you can see it's surrounding in the heart, in the pericardial sac. So this is what we call a pericardial effusion. And if you were to look at the scale on the right of the image, it's probably about 1 to 2 centimeters at its biggest. Now, not all pericardial effusions cause tamponade of the heart, but you can often see some features if tamponading is happening. And this will be squashing of the right side, certainly the right ventricle and the right atrium, in a sort of a seesaw appearance during systole and diastole. So, you're all happy? You can see the pericardial effusion there? Good. Here's another one. So, we can see the left lobe of the liver on the top, the right side and the left side, and there's a slither, certainly seen more adjacent to the left ventricle, but a slither of up to a centimetre or so around at the bottom by the lateral wall of the left ventricle, and also a bit at the top between the left ventricle, the left lobe of the liver and the right ventricle. Now here's a parasternal long axis, and we can make out the usual things. So there's a left atrium, mitral valve, internal part of the left ventricle going out to the aortic valve to the root of the aorta, and then just above that is the right ventricular outflow tract, As you can see, there's a little bit of compression during diastole of the right ventricle, and just above the right ventricular outflow tract, you can see there's a black stripe, and this is a pericardial effusion. And there's possibly a small amount of fluid seen between the posterior wall and the pericardium at the bottom. Just make something out. Now here's another parasternal long axis, and we can see here that at the top of the right ventricular outflow tract there's not a great deal of fluid seen there, but certainly at the bottom, by the posterior wall, between the posterior wall and the pericardium, there is a thin stripe of fluid that's seen. So this is quite a small pericardial effusion. Now, one of the ways to tell pericardial effusions from, say, adjacent pleural effusions is if you look at the descending thoracic aorta, which can be seen sort of appearing into the lower middle part of the screen, which is a black blob basically. Above and to the left of that is often pericardial, and below and to the left will be left pleural effusions. Okay, so on this view we can actually see there's a small pericardial effusion adjacent to the posterior wall of the left ventricle. Now sometimes you may see things that look like a pericardial effusion but could be a fat pad, and fat pads often show up as similar. They're very dark, but they may have little speckles in that can look like a starry night. So if you think about looking in the sky on a pitch dark night, looking at the stars, fat pads often look like that as opposed to completely black. But you have to be warned that sometimes if there is a pericardial effusion that is an exudate or an infection or old clotted blood, it may also have the same appearance. So we don't want you to necessarily be able to identify the cause, but whether or not you think this fluid is good enough. Okay, so in this case, this is a very poorly patient, and this is a parasternal long axis. Now you can see that you can make out where the left atrium is, the mitral valve. The internal chamber of the left ventricle looks like it's quite collapsed and it's very narrow, and there's the aortic valve and aortic roots in there with the right ventricular outflow tract on top. So it is the parasternal long axis view, but it does look very unusual because you've only seen normal ones before. So the other thing to note is the descending thoracic aorta. Now, if you look at the descending thoracic aorta here, above and to the left is fluid. So there is pericardial fluid around the posterior wall, and sort of also underneath the left atrium. Now you can see also there's a little black spot below the left atrium of the heart, attached to the posterior wall of the left atrium, and that's actually the coronary sinus. So you don't often see that, but it's the coronary sinus of the heart. So the other thing to notice is if you look at the descending thoracic aorta, to the left and lower part of the pericardium is actually some black as well. So this is also showing a small pleural effusion on the left side, as well as a pericardial effusion. So there's fluid both sides of the pericardium. So remember, pericardial fluid above and to the left, pleural fluid below and to the left. Now, if we cut round into our short axis views, you can often see fluid around there too. So you can see just around certainly the posterior and inferior part of the heart while it's beating, there is a little black rim around there, and this is a small pericardium. Okay, so now we're going to look at colour flow Doppler. Now remember, Doppler is able to tell us about things that are moving, and with colour flow Doppler, blue away, red towards, like Bart Simpson. And basically, it's quite complicated how it happens, and how it works. But really, you have to just sort of look at a few pictures and understand which way the blood would be going. If there's very, very high frequencies, so say there's turbulence due to a narrowed valve or something, then it often shows up as green. But on the whole, you get blue away and red towards. So here we go, blue away, red towards. And as you can see, the picture of this image here, there's blue showing the blood going down towards the aortic valve, so that's away from the probe at the top. And on the right hand one in diastole, you see there's blood coming towards the probe, so it's red towards the transducer, and that's coming through the mitral valve. So that's what you'd expect. If it was doing the opposite, then for instance in regurgitation of a heart valve, then you would expect the opposite colour flow. So let's have a look at some pictures. So this is a parasternal long axis with the colour flow Doppler actually activated, and when you use this feature, there appears a box, and you can see this sort of box that's over the aortic and mitral valve, and it will use a Doppler within that box range. The bigger the box, the more processing is required, and the more it can slow down the image that you're looking at. So it's preferable to have the box as narrow as possible, so you can just about see. Now you see both these there's movement of blue and there's red seen, and there's also some turbulence flow where it's gone lighter and with little bits of potential greening. So there's valve lesions to the aortic and mitral valve here, and it's showing flow during systole back through the mitral valve, which is opposite to what you'd expect. And during diastole, there's flow backwards, so blue away, as you can see in the top jet during the relaxing phase. So both these valves are abnormal in this image. So when we look at something like this, you see with the mitral valve, the blood is coming back during systole, and the jet is quite must be quite narrow, the regurgitant jet, so it's showing up as mixed colours with a little bit of greening, which would indicate that this is quite turbulent flow. So when it's not turbulent flow and not at grossly high velocities, you would expect it to be more a typical blue or red. So we need to just understand a little bit more about valves. So I'm going to talk about the aortic and mitral valves in a bit more detail. So we've already looked at pictures of the aortic valve, and certainly it should be 3 cusps. Only abnormally will it have 2 cusps, and it's a bicuspid valve, but normally it's got 3 cusps, and it looks like the Mercedes sign on the parasternal short axis view at the aortic valve level. So as we said previously, the normal thickness should be less than 2 millimeters of the leaflet seen. So sometimes on very young normal people, it can actually be quite difficult to see because it's not particularly reflective and it's not particularly big, thick cusps. So as we can see here, this is just where you would obviously look for evidence of valves here. So we'll just start the video going, and you can see often it's easier to see on the parasternal long axis. It's been zoomed to the area around the valve, so you can see it's opening and closing, and often you only really see it well when it's closed, and when it's closed, the center thing should be in the middle of the aortic root, which it is there. And on the Mercedes view, so it's the short axis with the Mercedes symbol at the aortic valve, you can see that the cusps nicely opening. There's 3 of them opening and closing. Okay, so if you want to have a look at the aortic valve in a bit more detail, you can use the apical 5-chamber as well, and you can see here the valve is opening and closing well. And if you were to put colour down there, you can see the flow away on this one. So this is blue away, so it's probably in systole, so it's being squeezed out the blood through here, and as it goes through, it's slightly narrowed and it's becoming turbulent. but you have to be cautious of always saying this is turbulent or narrowed flow, because it all depends on what settings you've got your colour um, to respond to. So you can set that for different velocities. Okay, so we mentioned the bicuspid valve earlier, and this is often congenital and associated with coarctation of the aorta. It's more common in males. And when you have this, there's an increased risk of regurgitation and stenosis. So here's a picture of a bicuspid valve there. So you can see there's only two leaflets when they're opening and closing. With aortic stenosis, the often leaflets are thickened and fused, and there may be calcification. So this would actually show up as a brighter area around the valve. So they're thicker and brighter, so whiter on ultrasound. And the movement is often going to be restricted. There may well be regurgitation, so it's a narrowed, poorly functioning valve which is thickened and not sealing off properly during diastole, which is basically the left ventricle relaxing. So blood is coming from the aortic root back into the left ventricle. So the characteristic chamber sort of compensation may be also associated with this, such as left ventricular hypertrophy. So remember we said earlier that the thickness of the left ventricular wall should be about a centimetre thickening by 30 to 40% on systole. Well, don't forget, if it's more than that, it could be due to things like aortic valve problems. So there's an increased pressure trying to push the blood out, and sometimes as well, when you have bad regurgitation, it can cause dilation of the left ventricle. So remember we said the internal diameter is most relaxed, which is the end of diastole of the left ventricle, should be no more than 6 centimeters. So often, for most people, it would be absolute maximum of just 5.5, but it's easy just to remember 6. Okay, so here's a parasternal long axis view and some schematic diagrams just showing the problem with the aortic valve. You see that it's thickened, so it looks much brighter than you would expect, and it's not opening that much. Okay, so when do we get obstruction? Well, often the valve has to be significantly diseased before it starts causing significant obstruction, and so greater than 70% of the valve area is often needing to be affected. So let's have a look at some other pictures too. So see this clip here. This is zoomed into the aortic valve, and you can see here the leaflets are thickened, they're bright, and they're not opening particularly well there. And this is a thickened aortic valve opening abnormally. It seems to be slightly moving more on one side, and that's the parasternal, the apical 5-chamber view. So if we put some colour Doppler on, we can see here in this aortic valve it's hardly moving, and it's thickened and bright, and during systole you're not getting massive flows going through it, so there's not a lot of red coming up into the aortic root, and certainly in diastole, when it's relaxing, there's this blue turbulent jet coming away from it, and so this is appearance of aortic stenosis with also regurgitation seen on the colour flow Doppler. Okay, so just a few more images really to look at aortic regurgitation, and sometimes it might be due to vegetations or other things that make the aortic valve not sealed properly during diastole. So we're looking now at the mitral valve, and the mitral valve has 2 leaflets which each have 3 little scallops on. So it's the anterior and the posterior leaflets, and the anterior is bigger and more mobile. And remember, they're attached by chordae tendinae to the papillary muscles. When you look in the apical, so the parasternal short axis at the mitral valve level, which is a top clip, you can see it looks like a fish mouth, or sometimes grandma's kissing lips. And on the bottom we've got the parasternal long axis, and remember we said that this valve leaflet can be thicker than the aortic valve, but certainly should be about less than 4 millimeters in thickness. And just remember about the EPSS, so that's the excursion of the anterior leaflet towards the septal wall during filling the diastole phase of the heart. So you can see that both those images are normal appearances, and we've seen those quite a few times now. So here's just drawings just to show you what they actually look like. So it's a bit like a smiley face when it's closed. Okay, so when it's abnormal, it might be abnormal due to stenosis, so thickened leaflets, and these are commonly seen in rheumatic disease, heart disease, such as you also see it with aortic valve lesions. And these images here, if you look at them, you can see that they're thicker, bright, and not moving the same as the normal images that you've used to seeing previously. So this is the typical appearance of a mitral stenosis. So often you don't have to do any measurements, you just have to look and you can see that there's something wrong with the valve. It just doesn't look right. So let's have a look at some more pictures. So this is the left image is the parasternal short axis at the mitral valve level, and you can see it's much brighter, enhancing, so it's shown up as white, and certainly the anterior leaflet is not moving to what you'd expect. The parasternal long axis is up on the top right image here, and you can see the aortic valve is thickened and not opening much. Now also note that the chamber sizes have been affected by this. So the left atrium is looking very large, so more than 4 centimeters just by looking at it using the scale on the right of the sector. And the internal diameter of the left ventricle is actually narrowed. You could say the walls of the left ventricle are thickened. So at rest, when they're not contracting, they seem to be significantly over 1 centimeter in thickness. Okay, so mitral regurgitation is common. In fact, regurgitation of some or all of the heart valves is commonly seen in normal subjects. However, the worse it gets, the more clinically relevant it becomes. And there may be different types of jets seen on the colour Doppler depending on the type of lesion we're talking about. So, as we said earlier, you can get left atrium dilatation as a result of this, and hyperdynamic and overloaded or flattened left ventricle. There may also be pulmonary hypertension due to increased pressure in the left atrium. So here's some images with colour Doppler on, and you can see the mitral valve on the top left image looks a little bit thickened, and there's a regurgitant jet during systole. And there's the apical 4-chamber view on the top right, and this one you can see there's in the left atrium there is a blue and a red jet during systole. Now there is also during systole a blue jet seen in the left ventricle. Now this is blood going down through the aortic valve. You can't actually see the aortic valve in this because it's not a 5-chamber view, but that's what that blue is. But look at the regurgitant jet. It comes down first as a blue turbulent flow and is so turbulent and so fast it's going and curling around the left atrium and coming back up to look like a bit of a loop. So there's a bit where it goes down blue and loops around and comes back red. So this is quite an intense jet that's circling the left atrium. So that's why the appearances are blue and red. So some other images of the mitral valve, and you see the top left there, it seems to be an abnormal excursion of the anterior leaflet. So when it closes, it seems to go backwards towards the left atrium, and things like this may be due to papillary muscle problems or chordae tendineae rupture. And you can see the top right image, there's paradoxical movement, and it looks like it's not closing properly and sealing properly. So when we've got those images of the coloured Doppler on, we can see whether or not it actually has an effect on regurgitation. Okay, so now let's look at global left ventricle motion. Now, we might have read formal echo reports on patients we've seen on the wards who have poor left ventricular function, and things quoted often, things such as ejection fraction, which is normally about 60% or more. That can be complicated to measure in real life. However, we wouldn't expect you to do that, but we'd expect you to look and be able to see that things aren't quite right, because we've seen enough normal images now. So let's have a look at this apical 4-chamber view. And remember what we said about the thickening and the radial contraction or narrowing of the internal diameter during systole. So if you look at this, there's certainly areas of the septum which are not actually thickening or contracting inwards, and also on the lateral wall. There is some thickening and movement of the apex of the left ventricle, which you can see here. And there's also a suspicion that the internal dilated diameter at the end of diastole of the left ventricle is in fact probably a large as well. So this might be dilated with poor performance. So just looking at this, you can see this this heart is not very well. Here's a parasternal long axis, and you can see here that the walls that you can see, which is the septum and posterior walls, are seen clearly, but the apex, around the apex, isn't seen due to rib shadowing. However, we can see the septal wall isn't contracting or thickening at all. There's a bit of thickening seen near the on the posterior wall near the posterior leaflet of the mitral valve there, and certainly we said that we'd expect the internal diameter of the left ventricle to narrow by about 30% during systole, and that does not seem to be the case. Remember what we also said about the EPSS, or the anterior mitral valve leaflet excursion, and it should normally flip up and touch the septal wall, or almost touch the septal wall, and it doesn't. It's very lackluster and not actually making much movement towards the septal wall there. Okay, so that's looking at general effectiveness of the left ventricle to pump blood during systole. But remember we talked about different blood supplies to the various parts of the left ventricle. This is a diagram taken from the textbook of clinical echocardiography. But at the top, you can see the short axis view through the mitral valve and the papillary muscles, and also the apical 4-chamber, 2-chamber, and it says apical long axis here, which is actually the same as apical 3-chamber. And you can see by the colouring that when the left anterior descending is shown as a light green colour. So these are the areas supplied by the left anterior descending commonly. The circumflex is shown as an orange colour, and the right coronary artery is shown as a red colour. So those areas typically give blood supply to that particular part of the left ventricle. So you can see, looking at these views, you get a very good a view of what is normally supplied. So if the left anterior descending was to be occluded, you would expect the anterior septal and anterior walls, as you can see in the top of the short axis, and around the apex and also part of the anterior wall seen on the apical 2 chamber to be affected. You also see the with right coronary artery, the inferior aspect of the septum and inferior wall would be affected, and that often extends as well to the right ventricle. And you can see on the apical 4 chamber that would affect the base of the septum near the mitral valve. And also the inferior wall is clearly seen on the apical 2 chamber. So if the circumflex goes, then or is occluded, then this is something where you would see on the lateral and posterior walls, which you can see on the short axis views, and also the lateral wall seen and posterior wall seen on the apical 3 chamber and apical 4 chamber. Okay, so remember, this is just to summarise exactly where you would expect to see it. And as we said earlier, you're more likely to see poor effort at that part of the left ventricle following occlusion well before you see ECG changes. So this is anterior wall. So you can see, looking at the parasternal short axis view through the papillary muscles, there's thickening and contraction of the lateral, posterior and inferior aspects. But if you look anteriorly, so anterior septal and anterior, there's very little thickening, radial contraction towards the centre. So looking at the this one, there is poor effort to part of the inferior wall in this apical 2 chamber view. So the proximal and distal parts, now the apex, are fine, but there's a middle section where there is poor movement or poor thickening and movement of the inferior wall. Okay, on this aspect, the inferior wall is not thickening and contracting in much, whereas the other walls are thickening and contracting in. So you can see that down the bottom left part of the this short axis view through the papillary muscle. So in apical dyskinesis, or this is abnormal thickening, you can see there that the whole of the apex doesn't seem to be contracting. The septum and the lateral wall are thickening and contracting inwards, but the apex isn't. Okay, so these features may be temporary if there's early reperfusion therapy, such as primary coronary angioplasty. And just to show you how this can change, so look at the contraction on the left of this parasternal long axis view, and this is following reperfusion on the right. So there is a difference. And here's another view looking at the apical 4 chamber, and certainly around the apex there's very little contraction and thickening, but following reperfusion things are improved greatly on the image on the right. Okay, so how do you know if something's new or old? Well, the signs of old infarcts, things can easily be seen because they have different appearances. So often with an old significant infarct, there may be dilation of the ventricle, there may be reduced and or abnormal movement of the ventricle wall, and they become less thickened, or certainly less than 10 millimeters, bright, thin, and more likely to form aneurysms. Whereas in new lesions, usually the appearance of the ventricle is normal in size. The wall thickening is the wall thickness is normal, but doesn't actually thicken with systole, and it doesn't look too bright, and there's no evidence of aneurysm formation, which would be unusual in this case. Okay, so let's have a look at some abnormal dimensions. Now remember, we talked about what we normally expect the chamber sizes to look like and also how they're affected during the cardiac cycle. So I just wanted to show you a case here of a lady who came in with a massive pulmonary embolus, and you can see we've got a subcostal 4-chamber view on the top left, and on the bottom right there's a the parasternal short axis view. Now, as you can see, the ratio of the right ventricle and the right side and the left side is abnormal. So we said that the right side shouldn't be more than 2/3 the width of the left side, and certainly on the subcostal 4-chamber view, we can see that the right side is much bigger than the left side. In fact, the left side has been collapsed down because there's no blood coming back into the left ventricle, and the left ventricle walls are almost touching each other. You can see that. So this is somebody who had a massive pulmonary embolism who came in with a sudden collapse and cardiac arrest. When we look at the parasternal short axis view at the bottom, we can see that the round donut, typical appearance of the left ventricle, is in fact become squashed, and the right ventricle looks like it's massive. So normally you get this sort of appearance in certainly acute massive PEs. Okay, let's have a look at these images. So they're both parasternal long axis views, but they're just still images, so they're not moving. We can see at the top left, this is a very dilated aortic root, and this is a patient who had an a proximal aortic aneurysm that was affecting the aortic root. Commonly in these patients, they also will have problems with their aortic valve functioning properly, and risk of getting life-threatening pericardial effusions as well, and tamponade. On the bottom one, bottom right image, this is somebody who had hypertrophic cardiomyopathy, and you can see the wall thickness of the posterior and especially the septal wall is absolutely thickened, even if this was in the systolic phase. So this person has hypertrophic cardiomyopathy. In this next slide, we can see that the left atrium, even though we've got no reference points with markers, we can see in relation to the other aspects that the left atrium and the left ventricle look huge, and this is somebody who had dilated cardiomyopathy. So remember, the maximum diameter that we'd expect to the left atrium would be no more than 4 centimetres, and the maximum internal diameter at the end of diastole of the left ventricle should be really no more than 6 centimetres. So actually in this one, this is much more. Okay, so we've covered quite a lot, and your brain must be feeling as if it's been fried at the moment. But hopefully you've assimilated some of this and have a bit more of an understanding and enthusiasm for looking at echo images. So in summary, we've covered the physics of why ultrasound machines are able to generate an image. We've looked at the modes of machines, and the modes are basically the B mode, or the brightness mode, and also we've looked at Doppler, certainly colour flow Doppler. We've looked at the views of the heart, so we've covered the parasternal views, which is along a short axis. We've covered the apical views, which has included the 4, 2, 5 and 3 chamber ones. We've also looked at the subcostal 4-chamber view as well. So 3 locations to look at the heart, and we've also looked at the normal appearances. So we know that the normal shape, size and function. We've also looked in more detail at valves. We looked at the valves that when they've become diseased and how they may be stenosed or regurgitated. And we know that the appearances and what would be typical appearances and what would be typical movements of those valves. We've also looked at effusions around the heart and also considered where a pleural effusion might be seen on echo. We've also looked at abnormal contractions and abnormal dimensions. So hopefully you will have a better understanding of the heart through the medium of ultrasound, especially echocardiography. So what will happen is you will also be given a crib sheet which will have a summary of the main salient features of this presentation to have with you for the rest of the study. Thank you very much for your attention.